Welcome to Airway Breathing Conversation, a podcast presented by the anesthesiology residents at the University of Saskatchewan, created to provide individuals of all levels of medical knowledge with anesthesiology-related healthcare information. This episode is part of our Abridged Ground Round series, in which highly knowledgeable and sought-after guest speakers present on a multitude of fascinating topics relevant to anesthesia. Join us for Ground Rounds this week, where Dr. Martin Pusic, a Harvard Medical School professor, pediatric emergency medicine physician at the Boston Children's Hospital, and scholar in residence at the Brigham Education Institute, discusses artificial intelligence in the context of medical education. Now, whether you are an anesthesiologist, resident, medical student, or member of the general public, come listen in as we demystify the incredible specialty that is anesthesiology, one episode at a time.
Some disclosures, we're going to get grant funding from the American Medical Association and some others, including the wonderful Royal College of Physicians and Surgeons of Canada. As Ryan mentioned, I have a role at the ABMS, which has, kind of part of the function of the Canadian Royal College, and sort of there to cheerlead for good research. And then the work I'm going to show is part of a kind of a large team, so that so it's not an individual's work. It's kind of a lot of people over the years. And then Ryan mentioned the connection to Saskatchewan. So here's my wife Andrea, and her father grew up in North Battleford. In fact, her father's father was the mayor of North Battleford for a long time, and they have a place up on Jackfish Lake, which you can see in the background here as we stand in a canola field. And so my boys who grew up in Manhattan would kind of have this overscheduled, pressured life in New York City, and then come July 1st, we would release them to Cognition, and up they'd go and have kind of just absolutely wonderful summers, and we would join for as much time as we could, and so that really enjoy that connection, and have kind of sought to maintain it over the years. So here's the outline of what I would propose. It's a bit of a schizophrenic talk, in that what I'm going to do is for the first part of it, talk about big data, precision education, kind of what's happening with data. And then halfway through, switch into talking about the way that intersects with artificial intelligence, and tell some stories from kind of my experience as a clinician educator, and then happy to hear of yours as well. And what I'll try and do is bring this in at the top of the hour, and then leave 30 minutes for question and answer afterwards. But feel free as well. I cannot see the chat, but if you put questions in there, I would rely on Henry and Ryan to bring them to my attention, and we can go on tangents if you prefer. So to start, kind of one of the areas of research we have is in people learning how to read X-rays, and so we show them an X-ray in a "you make the call" kind of fashion, and then have them declare it either normal or abnormal, and then right away give them some feedback. You got it right, you got it wrong, kind of bring it across like that, and so our idea there is to, the way a musician learns by playing their scales and getting them well, that we could do that for pediatric emergency medicine doctors. And so that when we do that, here are 18 residents learning how to interpret ankle X-rays. And so that each line on here is one resident's learning curve. And as they go from their first case on the left through to their 234th case on the right, and that's how many we had in the set. And on the y-axis is their accuracy, and so up is good. And so that so you can see that that they do learn. And that black line is the averaged learning curves across the 18. And I show this because to me it's phenomenal how variable each person's path is. And so that so when you look at it from an X-ray to X-ray learning point, one by one, and we can suck back in the digital environment all of how good they are at their 52nd, at their 73rd, at their 96th X-ray, we can then kind of really get a fine-grained look at what their competency development looks like. And we can get a look at, just really how variable their journey is and how even at the 234th, we've succeeded in narrowing them down, but there remains a bunch of variability as well. And so what we're trying to do in education now is with this learning analytics, precision education, big data, all of that, start to pull back this sort of fine-grained information and use it in service of training our people more efficiently and to a higher level. And I put up this table to kind of contrast our old way. I'm old, and so that, kind of I can attest to the traditional way of dealing with data in this second column here and contrast it with where we're getting to now. And so in the old days of epidemiology, data collection was really expensive. And so intrusive. You had people with clipboards and white coats and stopwatches going in, and to collect data was not straightforward. And because it was expensive, you didn't do it very often. Annual reports, quarterly reports, that kind of static reports that would come back well after the thing had happened. And we would do sample size calculations so that we could get away with the smallest sample size that would allow us to generalize to the larger population. Contrast that to a digital environment. Amazon tracks you for a year and it costs Amazon 2 cents to do that. But the economic potential of that 2 cents worth of data is said to be somewhere around $1,700. And so that delta between how much it costs to get the data and how much benefit you could get from the data is the opportunity that we're trying to exploit. We can collect that data continuously, and so dashboards can update every day, every hour, every minute, and so that you can really, really know what's going on right now, as opposed to what happened last quarter. And with these large swaths of data, the sample size thing becomes much less relevant. And in the old days, we would call that data dredging, and we would say you cannot make causal inferences. But even there, we are making progress in terms of ways of A/B testing that allow us to really, kind of tell which relationships are real and which ones aren't. And so there's progress there as well. And so the core idea is that kind of almost silently, almost slowly, almost in a boil the frog kind of fashion, we've shifted in our ways of thinking about data, and our mind shift has to go from scarcity to abundance. And how do we handle that abundance? And so this learning analytics movement capitalizes on that. And so this is from the US Department of Education, which, thanks to President Trump, does not exist anymore. But the learning analytics refers to the interpretation of a wide range of data produced by and gathered on behalf of students in order to assess academic progress, predict future performance, and spot potential issues. So it's this idea of prediction and this idea of early warning systems that we're using this data for. You may also hear the words precision education, and that basically has the same definition, but with more of an emphasis on the individual. But again, the idea is getting a ton of data and then figuring out how to make education more precise as you go along. And so I was at NYU for a lot of years, so that Mark Triola and the group there put up a map of, kind of all of the data systems that could come into play for the education of one of our medical students. And so in the top half of this, what you can see is the, kind of the systems within the medical school. And so the curricular content system, the learning management system, their e-portfolio that they submitted to, student information system, and so on and so forth. And we had a topology of all of that data that we were collecting, and we would dump it here into this big shoebox in the middle called the Education Data Warehouse. And the way we did that was whatever came into any of our systems, we assured that we could dump it in a sort of granular fashion into the education data warehouse without knowing what we were going to do with it. which is a very, very different way of thinking about data compared to the data scarcity mindset. But the idea was to have it in a digital format that we could then start to make associations with the EMR, with the practice network, with the clinical data warehouse, where the clinical informatics people were doing the same thing of creating a shoebox in which they would put a whole bunch of data that would be for research purposes, and that we would figure out later on what we were going to do with that particular data. And so this notion of collecting big data falls into, kind of the way I think about it is, kind of the way the scientific method works, which is that you observe some data, you then, having collected and observed it, you interpret it, and only after having interpreted and analyzed it do you act. But what has changed in in the interim is each one of these things, and we'll go through each one as we go along. But we're collecting more data, we can analyze it better, and then our systems where we do actions are increasingly digital as well, and so we can put that data to work. Okay, so let's start with the large amounts of data. Kind of we have gotten very, very used to activity logging, in which your phone or your watch counts every single step you take, or kind of collects every heartbeat that you have, and so that we can diagnose atrial fibrillation the moment it starts. And that same sort of activity logging can be done in service of education. And so I've already talked about radiology, where kind of everything happens in a digital environment now, and so that the minute to minute learning that's happening is leaving an imprint in which we could, in theory, collect learning curves for each and every individual learner as they go across through there. Surgery is no different. And so what used to be a black box of, kind of whatever happened in the OR stayed in the OR is no longer true in a digitalized environment, in which each one of these probes on a Da Vinci robot can suck back X, Y, Z coordinates and video and proprioceptive data and the like, and bring it through. And so that in the same way that's those streams of data inform the surgeon as to what's happening in the field, that can also be fodder for education, and we'll talk about that in a bit. And then your $27,000 on Black Friday anesthesia machines are essentially a portable computer, in which a whole bunch of data streams backwards on an instantaneous manner. And again, in a big data mindset, each one of those things can be used in service of the training of your residents. And so that so there throughout our environments, whether it's the medical school, the hospital, the clinics, the OR, wherever it is becoming increasingly digitalized. And so that so there are sensors that can pull back data that is being used, kind of in all sorts of fields. But the claim here is that they can be used for educational good as well. And so that the way we thought about it at NYU was that our job at the medical school was to create sensors wherever we could, and sprinkle them through so that they made that education data warehouse in the middle as smart as possible. And so it's really a wiring or instrumenting task, and that's what our generation's innovations will be as we bring forward. Now, having collected all of that data, we have to make sense of it. And so that's where the learning analytics part of it, with that word interpretation of a wide range of data. So not only have we advanced in terms of what we can collect, but we've advanced in the way we can analyze it. And so learning analytics sits at the intersection of three different fields. And so that the computer scientists and the statisticians finally went on a blind date and birthed data science. And so that so all of the algorithms and AI that you know about are from that. But each time we use data science, we have subject matter experts. And so in the business world, it's business analytics in that yellow circle. In the clinical world, it's clinical analytics, with clinical sciences as being the thing. And for us as educators, what we bring to the table are the learning sciences. And so that how do you learn? How do people learn? How does feedback operate? What is CBME? All of that stuff has to inform what we do with this treasure trove of data. And it gets even more complicated when, kind of you bring in subject matter experts who are both expert in learning sciences and in some clinical domain. And so that so where that green circle overlaps with the learning sciences is where you anesthesia educators have particular expertise. And now the idea is to bring it all together with the data sciences and bring it forward. And one of the key things there is a change, again, a change in mindset from the traditional data world to the new one. And so that data mindset, kind of happens here in this middle from this model of how data works in the business world from the Gartner Group. On the x-axis is how difficult it is to collect that data, and so that from easy all the way across to difficult on at the far right, and on the y-axis is how helpful that data can be, and so up being good, and so more valuable. And so that here the notion is that if you put in the effort in terms of instrumenting the environment, in terms of putting in the all of these digital things, you can go from describing what happened in the past, quarterly reports, annual reports, updating every quarter, that kind of thing. And so to looking at what happened and why did it happen in the past, and then based on your analysis, trying to reason to what's happening in the future. Now, the idea is that you've got so much data that you can start to make better and better predictions. Those early warning systems that something may be off and what will happen for this particular learner. So seeing them halfway through their learning curve and then trying to figure out what's going to happen moving forward is the hope for these systems. And I'll show you an example in just a second. And then that's called predictive analytics. And then there's this notion of prescriptive analytics in which not only do we predict what will happen, but should we do about it? How can we make the best outcome happen as we move forward? We'll come back to this diagram in a bit. But here's a data representation from NYU that we used in terms of figuring out who should be interviewed for medical school. And so that NYU would get 10,000 applications for its 100 slots. And so that it was a big, sizable problem for us because waiting through all of those applications was not straightforward. And so that, and one of the key things that they would do is they would winnow down their number of applications and then have two faculty members go into the application in depth. And then the two faculty members would determine interview yes or no. And ultimately they would interview 500 people for the 100 slots. And so that so at a certain point, the dean read a book and said, we should be able to automate this. And so that off we went and took all the data that we had over the previous 10 years. And so what you're looking at here is the data from 1,000 students. And so across the top, there are 1,000 columns in this data representation. So they're very, very thin columns, but the colors, kind of are each one cell. And then on the y-axis is everything, every bit of digitalized information that we had on the person, so that they're, their grade in math in high school, and so that are undergrad on their prerequisites, and what they whether or not they had an advanced degree, how many publications did they have, did they do leadership or athletics, and so on down there at the bottom. And so that everything we had in there, we then kind of looked at these 1,000 students. So remember, this is historical data. So we also had data on how they functioned in medical school during their 4 years with us. And so that so it's a predictive model. Here's the data that we have when they were admitted. And so how did that data predict how they did within medical school? And so so we created a predictive algorithm that then, we ran in a randomized kind of fashion or in the background the subsequent year. And we compared the predictions made by the algorithm with the predictions made by the faculty. and they matched up pretty well. And so ultimately NYU flipped to a machine prediction algorithm. And so by and large, the machine predicts who should be interviewed with human oversight as it goes along there now. And so I can talk during the Q&A about the implications of that. And a lot of the faculty were not happy about the thing because they enjoyed reviewing the dossiers of these really, really accomplished individuals who were applying to NYU. But this is the dean's happy because he feels that he saved $200,000 a year that he was paying the faculty to do this chore. So similarly, kind of what's happening in your world, in the surgical world, is video-based analysis. And so the video being data. And so here are a couple of screen captures from a study done at Beth Israel in which they downloaded surgical videos from YouTube. And these surgical videos from YouTube, they then put into an AI toaster and coded up what was cautery, what was forceps, what was hand, what was your knuckle, what was your distal phalanx, what was your MCP, and so on, and fed all of that data into the AI algorithm. And again, in a similar fashion, you can see on the left here these fingerprints of what's going on in the OR as they go through, and fingerprints that are very, very different, whether it's an appendectomy, a pilonidal cystectomy, or a thyroidectomy. And so the use of these instruments and the use and the different actions that happen vary over time over the course of the operation. And what's good is that the AI can make sense of the video and come back with, kind of really tight characterizations of what's going on. And the promise here, and it's still at a research level, but in this Goodman study, they were able to tell the difference between on subsequent videos, on newly collected videos, this algorithm could say who was a resident and who was an expert, and so it could distinguish between somebody doing the thing well and somebody not. In a more sophisticated fashion, Dr. Andrew Hung at Cedars-Sinai Medical Center in Los Angeles is looking at these sorts of digital trails of a surgeon's functioning in XYZ planes. And so you can see here on the left what the economy of motion of an expert compared to on the right, a junior resident doing exactly the same operation, a bladder mobilization. What's phenomenal is he's able to take multiple experts and look at and predict based on these imprints what happens, the degree of nerve sparing and the recovery of nerve function to the penis a year later. And so that you're going to, again, this idea of prediction, they're able to do and able to bring forth in a really, really, kind of important fashion. It's not ready for prime time, but the point I'm making is that in collecting all of this data, the analysis part is we're not only collecting more data, we're getting better at analyzing it, and we're getting better at analyzing different data, video, not just zeros and ones on a form as we go across. And so that in addition to these new sensors that I talked about in terms of the amount of data that we're collecting, we now have new interpreters. And so the large language models everybody knows about, the sophistication of the statistical tools is unbelievable. Text analysis tools, this is invading qualitative land. And so that our ability to sling and interpret text is advancing incredibly. And so that everything is data now. And these interpreters are going to take us from, again, a mindset of interpretation scarcity, in which, you have high priests of statistics who, kind of do the statistics in an almost mystical fashion, to a democratization, to an abundance of analysis that's going to go throughout the environment as well. So again, not only will we collect a whole bunch of data, but we will have interpreters that will allow us to make sense of it that'll be distributed all the way across. And so again, kind of the landscape has changed, and in this mindset of abundance, kind of we need to do things differently. And then the other thing that I, kind of point out is that here in education land, that data is feedback. And so that in the same way as we've gone from, kind of data scarcity to data abundance, you and I are moving from the annual review to the continuous surveillance feedback that, kind of could be great and could be awful. And so that, and yet we can do it now. So we have to make a decision in terms of to what degree are we going to come across. And to go back to my ankle x-ray example, here's that averaged learning curve. And in a data scarce environment, that's what we taught to. We taught to the average person and we would, kind of call it a day. And if you fit and you were average, that's great. Kind of we could our data was in sync with the way you were learning. But I've already shown you this, and so that average curve is the lived experience of exactly no one of our people, kind of as they were learning to interpret the ankle x-rays. So again, in this data abundant world, the ambition is to meet the people where they're at and bring it across. And the degree to which we can do that, we're learning as we go along. Okay, I need a sip of coffee, Oh, good. Okay, onwards, acting. So within these systems, kind of having collected the data, having interpreted it, what do we do? And here the notion is to adapt to that individual learning curve. And so that, so I won't go through this in glory detail, but it's the components of an adaptive learning system, again, from the Department of Education in the US. And so what they're saying here is that we know a certain amount about the student, kind of in terms of our student information systems. And then we have that shoebox of data that sat in the middle of my NYU diagram back there. And so with these treasure troves of data, we're now able to predict. Okay, so that's what we've talked about with the observe and interpret part of it. But the prediction becomes in service of an adaptation. And so that we somehow change what we put in front of the student, and we individualize that based on what we know about that student on these two different databases. And so the content of student A is different and customized and individualized compared to the content of student B. And so that, and the student interacts with that content. And so in my example, an ankle x-ray, and they either get it right or get it wrong. And so if they get it wrong, that gets written down here. If they get it right, that gets written down here. But it works in service of an ongoing assessment of how good they are and when they competency out. And so it gets fed back into the predictive model. The predictive model is a little bit better because it has a new data point, and the whole thing swims, kind of around and around and around up here with the data getting better and better as it goes across, and in theory, they then competency out when they're good enough and come through. Now, this isn't you and I still have a role in this brave new world, and so that continuously updating dashboard tells the faculty and teachers what's going on, and tells the administrators how much they're paying for what's going on, so that again, if it goes out of control, the person needs remediation, they need individualized coaching, we can do that. But again, the notion is that we can adapt the learning based on sort of this better data that we have as we go across. And so again, kind of the notion is that we can start to think about what is happening. And while it's more difficult to collect that data and it costs money to build these systems and the like, the idea is that that would be more valuable because we would, kind of recognize the human capital in a better way. Good. And so that, so again, the force field, kind of adaptations that the robot can do. And within the Gartner model, kind of what they point out is that human input is really, really important in what happened in the past kinds of things. But as you go across and the machine starts making predictions, it can offload us. And so that may be good or may not be, whatever you think about that NYU admissions example. And in this brave new world, there will be loops that you and I don't need to be in. And so that, again, kind of it may be that we need to be in there in order to monitor the decisions being made, but it may be that it can go directly into action. And so that's the field where we're arguing about and bringing it across. And so again, kind of what I'm saying this is that it's changing all around us in society in general, and there's no exception to education is not any exception as we go across, and we would do well to recognize it and advocate for education across this field. Now, kind of this is the big data world, kind of what happens when you introduce generative AI. Well, kind of the gist of it is that each one of these things gets affected and each one of these things gets amplified. And so that generative AI means it generates data. And so that if you thought there was a lot of data before, there's even more now. And so that what will go from scarcity to abundance could go through to overwhelming fire hose. And so the algorithms and the artificial intelligence, this thing and analyzes really, really well. And we're going to talk about that in a second. And then within the systems, how do you systematize AI? And bring it forward. And in many respects, what the AI may help do is to take this last part, kind of the part that required the human to get you from the data through to the action and bridge it for us and make this even narrower as we go across. And so so all sorts of potential there. And so what I'd like to do now is, kind of no one can really get their head around everything that's happening in AI, but I'd like to tell a few stories about, kind of from my own experience in this regard for our discussion as we move forward. Before I do that, just to point out one important difference or one important notion with respect to generative AI. And ChatGPT in particular, I love the way they name themselves because in reality there are two innovations in generative AI. And so that on the left is the notion of chat. And it's the idea that they have made such advances in natural language processing that we can interact with the thing with our way of speaking. And so that kind of knowing exactly what page and up to date you have to get to find that algorithm or whether the algorithm's there or not. You don't care how they structure ChatGPT because you type in your questions the way you would question it. And so that we'll talk in a second about the iteration, but this is part of, kind of what allows this thing to work so well is the fact that we can interact with it in natural language. And then the GPT, the generative pre-trained transformer, is the second part is that in response to our prompts, it can generate stuff that never existed before. And so it's not like Google where you go find something that exists and then pull that something that exists and bring it back. Instead, this thing uses its, machine-like or machine-ish wisdom to generate something that responds to your prompt, something that never existed before. And so so let me, kind of show you that in a diagram. And so in a chat GPT session, you say something, it responds. You then take that response and say something new, and it responds to that, and so on and so forth. And it iterates as it goes across. If you were to do that with Google, kind of Google gives you back what's out there each time in a standardized response. And if you do kind of a search with these three words, it'll give you that same answer each and every single time. And so as you go through this iteration, you are the one who has to get smarter. Google stays the same as you go forward. What's different in a chat GPT session is that you get smarter, it gets smarter. You get smarter, it gets smarter, and you both converge on an optimal answer. And so as it's going across, it accumulates a sense of your session. And if you want to, you can tell it about you and what kind of answers you like in the whole bit. And so that it, in an eerie fashion, kind of starts to, kind of develop or converge with you on the ultimate answer. My point is that it's a different way of interacting that you have to take into account. And so that in this scenario, kind of, I'm going to show you some ideas, but kind of it's on you because this is such an individual thing to teach yourself. And what I tell people to do is just sit down with whatever application you're interested in, and so that kind of thing, and just say to it, walk up to it and say, teach me what you can do. And then have a conversation as it goes across. And the thing can teach you about the thing is the fascinating part of it as you go forward. And so that's the advantage of the natural language interface, and it brings it across. And so these slides will be available afterwards. And, kind of if I were starting out fresh, these are as a clinician educator, these are the four that I would look at, kind of out of the box. And so that you may have already, but kind of a Saturday morning spent with a nice cup of tea and dedicating some time to this is the way to learn how to use these things. Okay, on to the stories. And so at a certain point, I got asked to give a talk like this to the American Academy of Neurologists, and that brought into my mind how I learned neurology, which was badly. And so that then, and in particular, I could remember neuroanatomy in the circle of Willis. And so that time, so I thought, why don't I pretend I'm a modern medical student learning how to interpret the circle or how to use my knowledge of anatomy of the circle of Willis. And so I went to ChatGPT and I said to it, kind of, hey, in the context of teaching someone clinical neurology and the diagnosis of various types of stroke, list the signs and symptoms of a person who presents with an embolic stroke at the circle of Willis, and break down your response by vessel, and detail what would happen with a stroke at that particular part. And it comes back with a list exactly like I asked it to, kind of a nice list there. Another nice feature is, kind of now create a table where each of the arteries are columns and the possible signs and symptoms are rows, and place a marker in each cell where that sign or symptom shows up. And it does that too. And so that it shows a grid with check marks all the way across. Now, the small eensy problem is that much of it is wrong, and so that but it constitutes a great start in terms of bringing the thing across. And when I say it's wrong, like a middle cerebral artery stroke, it doesn't say anything about kind of what happens to your face and the asymmetry there and the like. And yet, if I then go on and say generate 50-word case summaries, kind of for each one of these things, it does exactly that. And so the point is that this would be a lousy thing for me as a medical student, or it could be a great thing for me as a medical student if my educator said, do this in ChatGPT and come back to me and show me all of ChatGPT's errors. And so the medical student has to sort out what's real, what's not real, and bring it across and correct the thing as it brings forward. So at that point, they learn their stroke anatomy, but they also learn about the limits of ChatGPT and how it makes its errors as it goes forward. But if I'm a clinician educator and my job is to come up with cases that demonstrate embolic phenomenon at the circle of Willis, even though this stuff's wrong, it takes away 70% of my work. And so that in terms of bringing it across, and so I go through and correct it. But that correction takes much less effort than generating the thing from a blank page as you go forward. And so fixing this table, kind of won't take that long to the expert coming across. And so for fun, I then said, these things are kind of wrong, but can you draw the circle of Willis with anatomical labels for me so that I would get a sense of how ChatGPT was thinking about this? And so this is a companion application called Dolly that draws it. And this is hilarious, right? And so that the circle of Willis is a perfect circle. And then I don't know about you, but this maybe this person was Greek because they have a Doric column that supports the whole of the brain right there in the middle. And so so fascinating what its underlying idea of what the circle of Willis is. And so again, the point is that this thing works to a certain degree, and so that in terms of giving you fodder for what's to come, but but its accuracy we have to worry about, and so this from UNESCO is a guide to when you should or should not use ChatGPT in education. And so so it's useful in the sense that it gives us it places the person and the responsibility in the right place. And so its first question is, does it matter if the output is true? Well, for you and I, that's always a yes. And then the next one is, do you have the expertise to verify that the output is accurate? Super important, right? So a medical student figuring out their circle of Willis embolic phenomenon from ChatGPT is not, and therefore it's unsafe for them to use ChatGPT in a unmonitored fashion. But if you do, if you're a neurology educator, then down here you come. And then the next question is an important one. It's, are you willing and able to take full responsibility, legal, moral, and the whole, for missed inaccuracies? Are you able to correct this? And I find it hilarious that there are all sorts of spelling errors in here as well in this human generated thing, but all good. But if you're willing to take responsibility, then they say it's possible to use ChatGPT, but with caveats around, kind of you too are responsible for the thing as you go forward. And so again, kind of this kind of insecurity around using it is proper. And yet that doesn't say that it's not useful as you bring it across. Okay, so next story is around tough cases, and so so I'm a pediatric emergency department physician, and I do get tough cases, and we all do. And how can this thing help? And so there's a good study from just down the road from me here at Beth Israel and Stanford, in which they looked at the use of large language models in reasoning by internists. And what they did was they took 50 internists, half of them senior residents and half of them fully fledged internists, and looked at whether or not ChatGPT helped them solve difficult case vignettes. And so these case vignettes were ones that had never been on the internet, were known to be difficult, and they knew the properties of them, and there wasn't a single answer, but you had to generate a differential diagnosis. And so that they took those differential diagnoses and in a blinded fashion scored them, and then looked at the scores as the outcome measure to see, kind of whether ChatGPT helped the physicians in terms of solving difficult cases. And so they randomized people to either a ChatGPT group or an up-to-date group, in essence, or where they got to use whatever resources they would normally use to do this. And then for fun, they had a ChatGPT alone group. No physician need apply, and they brought it across. And so when they looked at this, kind of the score was out of 100 on the y-axis, and so up is good. And so when they looked at ChatGPT 4 alone against the physicians with conventional resources, ChatGPT won. And didn't win by a little, won by a lot, right? And also notice the variability. There are, kind of cases way down here at the south end of the score thing as you brought it forward. Okay, well that's fine. Kind of great that we have ChatGPT now. So if we join ChatGPT with the physician, then it's going to be better, right? Right? Wrong. Okay, so in fact, when they had in their ChatGPT plus physician group, they scored no better, perhaps a little bit better, but it's still with that wide variability as it came across. And so I leave it to you to reflect for a second about why that is. But I talked to the investigators here, and I'm kind of again they're just down the road. And what they feel is that the physician plus GPT thing, the physician does not know how to use ChatGPT in an effective manner yet. And so that what they were finding was that the people were using ChatGPT the way they would use Google. They were only using it for small sub questions of what was going on, things that they thought they were confused by, and so would look up for that little piece of information that would be for them the final part of the jigsaw puzzle, when in fact the way to use it for difficult cases is to dump the whole case into ChatGPT, let ChatGPT do its high level thing, and then your job is to make sure that it's okay, that akin to that UNESCO flow diagram, that there isn't some way off weirdness that is missing, or it isn't drawing the circle of Willis with a Doric column, but instead, kind of that the thing passes the sniff test of an expert bringing it across. And so again, there's kind of the thing out there that human brain plus computer is greater than human brain. But that's only true if you train the person how to use that. And so there has to be, kind of a phase in which human plus computer, that interface, that interlocking of the Venn diagram, you know how to use. And so that you know how the notion of how excuse me, how they differs from the way you search Google to the way you search with ChatGPT, the way you get to an answer, and so that you understand that kind of iteration and you understand how to develop prompts as you go forward, and only then will you end up with kind of a higher level approach to the particular thing. And so I made the point of, kind of that we changed in the way we approach data, and I've made the point that we changed in the way that we go from scarcity to abundance of feedback. The same thing is happening around cognition. The same thing is happening around thinking. And so that we're moving from a thinking scarcity thing in which you and I are a precious resource that has to be apportioned and metered and kind of focused on things, to a cognitive abundance landscape in which, in the same way that kind of I talked about sensors and the whole bit going across the whole landscape, that cognition is going to do the same thing. And so that qualitative studies are going to go from interviews of 15 people to interviews of hundreds of people, where those transcripts get analyzed by Copilot or by ChatGPT or whatever it is. And we'll go from just analyzing transcripts to analyzing actual videos of interviews, where we can interpret the body language and the facial expressions and all of that as part of what we think of as a qualitative study. Quantitative studies are going to change as well, in which we're going to go from just thinking about numbers in linear models to analyzing quantitatively video, like I showed with the surgical example. And we're going to get more and more sophisticated nonlinear models that take into account all of the complexity that's going on and be able to use that in a timely fashion, as opposed to what happened in the past kind of fashion. And so this kind of thinking, this kind of analysis that used to be really specialized will become democratized, and we will be able to tackle the full complexity of what goes on, and in a fashion that's way faster than the way we used to in the past as well. And so again, kind of in this augmented intelligence type of landscape, things are going to change. And so perhaps for anesthesiologists, I can't predict, kind of what part of your tasks will change, but they will. And what I can tell from, kind of my cognitive specialty is that we're, kind of pediatricians are going to move from being providers of answers to identifiers of questions. And so what's the relevant question? What's the prioritization here? And then bring things forward. And so that we're not going to be about routinization. We're not going to be about doing the same thing over and over again with increasing efficiency. We're going to be about adaptability. We're going to be about customizing things for the patient, for the unique patient and the unique circumstances that are operating right now, and be able to really customize to bring them across. Okay, one more story. This is from my practice in the emergency department, and kind of I'll tell the short version of it. But basically, I was on one Thursday night, and in came a patient with really bad tinea capitis, and I see this every blue moon. Like it's not that common a diagnosis, and each time I have to look up griseofulvin. There's different forms of it, ultra micro-sized or micro-sized, and comes in these granules, and the whole thing affects your liver, and you have to worry about it. And the dosing of it is it comes in suspensions and tablets, and which age kid gets which one is also complicated. And the whole thing's a mess in which I know it's going to take me 15 minutes to write one prescription. And so in this case, my patient was a lovely, lovely 8-year-old from a foreign country speaking a foreign language, and they didn't speak a word of English. And so then if I think griseofulvin is complicated, the patient has to go back with a handout that is about 3 pages long that has all sorts of stuff, and it's bad in English. It's really, really bad in Haitian Creole, and so a dilemma, and kind of a normally I would muddle through this. And on this day, I had bought my subscription to ChatGPT, and I said to ChatGPT, "Hey, this write patient discharge instructions for a child who weighs such and such, who needs this much griseofulvin and the whole bit. Go." And it comes back with great discharge instructions. I look at them, I change some of the words, I suggest that it shorten it a bit, and I suggest that it change the reading level to grade 6 so that it would be more straightforward. It does that. I like the new version at the grade 6 level. It keeps the meaning, but it's more straightforward to understand. I then say, okay, translate this to Haitian Creole. It does that. But I don't speak Haitian Creole. I am not expert, and so that I cannot judge it, kind of according again to that UNESCO diagram. But then I go, okay, without using the original text, translate this back into English. And so it back translates it, and the back translated version is different, but the same, kind of in the sense of all the key points are there, and it's come across. And so that I take that initial Haitian Creole thing, I then scrape it into my discharge instructions in the electronic health record, and then go off with an interpreter and speak to the patients. But was pretty pleased with myself with kind of the having been able to surmount some of the complexities of the thing. And so that now, kind of I use this all the time. And so the more individualized the patient, the more unique the circumstances, the more I can bring the thing across and use it well. And so last night, the typical question was, I had a case of Prader-Willi, a child with Prader-Willi syndrome who had, kind of left-sided neck swelling, which was, kind of making them drool with questions of whether he had a deep retropharyngeal abscess versus, kind of parotitis and the whole bit. And so off I go to open evidence. And I say, what are there special considerations in a child with Prader-Willi when it comes to, kind of deep neck infections and the whole bit? And then and thankfully, it comes back with no, not really, kind of it goes through. And so that you have to worry about the regular things you have to worry about. But I felt more confident going in, knowing that there wasn't some secret vulnerability that a Prader-Willi kid has compared to somebody else beyond, kind of what physically I saw there as I came across. And so it makes me better, kind of at my age as a clinician, kind of all of a sudden on that Thursday night, I'm a better clinician. And I'm a better clinician now for the way that the delta between searching up to date and searching a large language model is in individualizing to the patients that I see. And so I think that we can use that for our teaching. And again, I'm not going to go through this in detail, but I use it all the time for my learners. And we, I'm at Harvard, I'm at Boston Children's Hospital, I'm in an elite educational institution, and we have zero policy around how we teach people with AI. And so that we're making it up as we go along, but all of our trainees are using it, and they're kind of very, very open evidence dependent in the same way as modern taxi drivers are GPS dependent. And so that has all sorts of implications for you and me, but might as well run towards the fire. And so so here's a bunch of ways that you can use open evidence or ChatGPT right in the emergency department and have them like in my Prader-Willi example, go deeper and go surer about what they're doing with their patients as they go across and answer all of those little questions that they have that they might not want to ask you, or that you might not have the answer for. You might, kind of come back with vague answers. So again, this, UNESCO, I take full responsibility, legal, moral, etc., for inaccuracies applies, and yet within this framework, we are able to do a lot of good. And again, kind of this is just to say that there's a bit of technique to prompt writing, and so that you need to kind of take that on and just walk up to ChatGPT and say, what are the elements of a good prompt? And it will tell you, and then similarly, you can put in your prompt, and then the next iteration say, make my prompt better, or what things would make my prompt better, and it'll tell you. So I want to close with the last example, and I think it's sort of a more meta example, but ChatGPT, large language models, open evidence are only the latest in what it promises to be a stream of innovations that are going to disrupt the life of a clinician educator like me and you. And so that one of the things you can do is teach specifics about, kind of large language models, but the other is you can step back from it and say, kind of here's how I adapt to new things. And kind of in the past, the way we would learn and what was great was becoming more and more efficient. Kind of we'd have this false god of efficiency here. And the slicker you were with your central line axis, the faster that you could do it, the better a clinician you were. And so that's still good. Kind of lots of people want us to be efficient and measure that and come back to us with all sorts of metrics and the whole bit. But increasingly, kind of our ability to
Good
adapt,
morning, Lee. Good.
our ability. Our ability to adapt to new situations is the point I'm making is that this thing is just going to get canted a little bit towards the adaptability pool, towards us being able to innovate. And so innovation is inherently not an efficient thing. Think of a researcher who worries about tsetse flies in and flies to Ghana because there's a particular kind that they, kind of thing. I'm not coming up with a good example, but the point is that, kind of our ability to adapt is going to be much more valuable as we go forward, and teaching people how to adapt to new things is the opportunity here. And so these are two immigrants to the U.S. Vinod Khosla was the CEO of Sun Microsystems, and he's famously said, "In 10 years we won't need doctors." And Abraham Verghese on the left is a professor of humanities at Stanford, and he says that we'll need a stethoscope for 200 years in the future because of what an act of humanity it is to lay a stethoscope onto a chest, and that we need to preserve that. And so that these two, kind of poles of, kind of what this AI revolution is doing to our curriculum needs to be embedded and negotiated and thought about and brought forward. And so that's what we're trying to do. And there ain't no right answer, but we need to adapt, and we need to, kind of find some middle ground that allows us to take advantage of, kind of these affordances while also thinking hard about the degree of human input that advantages our patients most. And in some respects, we have to be willing to hear that maybe this thing is better done by the robot than by me. And so in conclusion, kind of, I think you and I are faced with wicked problems that have no clear solutions. They're difficult to define, they're complex and involve humans and the like. And those are hard, but kind of the hope is that these things are going to help us solve some of those problems as opposed to just adding to them. And so it's going to be a balanced kind of thing, and we'll see if it works out. But I hope, kind of in laying out some of these thoughts that I've helped you think more deeply about them and can apply them to the work that you do. And so in summary, kind of think about that observe, interpret, act type of thing, and think about the abundance shift that's happened. That means that you and I as educators have to think about sensors in our environment and have to think about interpreters in our environment and where they're best placed. And then, but with the responsibility to take legal, moral, et cetera, responsibility for the thing and use our expertise for good.
You've been listening to Airway Breathing Conversation, a podcast hosted and presented by the anesthesiology residents at the University of Saskatchewan. Please note that while this podcast is run by healthcare professionals, it is intended for educational and entertainment purposes only. We are very thankful to our guests for taking the time to share their wisdom with us this episode, and a very special thanks to you, our listeners, for tuning in. Don't forget to follow us and our associated USask Anesthesia accounts on social media. You can find all our social media links on our Linktree page at linktr.ee/abc_podcast. You can also find the department's social media links on their Linktree page at linktr.ee/usask_anesthesia. We'll see you next episode, but until then, stay calm, take a breath, and always remember your ABCs.